So for the interest of time, I'm going to review only select landmark studies to illustrate how we tailor first-line treatment for advanced stage aggressive lymphomas. And I just want to put a disclaimer that some oncologists might suggest different therapies from this. And I think that there's really no right answer, but I just wanted to show that there are ways that we are thinking as oncologists about how to adapt chemotherapy to aging bodies. So I'll discuss both non-Hodgkin and Hodgkin lymphoma. So as a background, lymphoma is a cancer of a very specific type of white blood cell called lymphocytes. And lymphocytes are an important part of our immune system, and they live within the lymphatic system and the spleen, which helps to filter blood. And so as you can see here, you have lymph nodes all throughout your body. Lymphocytes are also in the bone marrow, so they're made in the bone marrow, which makes blood cells, as we learned from Dr. Jeong. And the main difference between Hodgkin lymphoma and non-Hodgkin lymphoma are these cells on the left, which are owl-eyed, and they're called Reed-Sternberg cells. So if the Reed-Sternberg cell is present in the lymphoma, then it's called a Hodgkin lymphoma. And if it's not, then it's non-Hodgkin. And there are over 50 subtypes of non-Hodgkin lymphoma. So the most important part of lymphoma treatment is getting the diagnosis correct, because then we can really address the cancer with the right therapies. The other important factor about lymphoma is staging. So this is the Ann Arbor staging system, which illustrates how widespread the lymphoma is throughout the body. So advanced stage refers to stage 3 and stage 4. And stage 3 just means that lymphoma is present above and below the diaphragm. And stage 4 means it's in an organ outside of the lymphatic system, like the bone marrow or other parts of the body. And unlike solid tumor cancers, such as lung cancer or colon cancer, some stage 4 lymphomas can actually still be curable. So I'll first review treatment of Hodgkin lymphoma. Now, Hodgkin lymphoma affects two main age groups. So people in their 20s to 30s, and there's a second peak for adults over age 60. And the reason there's a lot of studies looking at older adults with Hodgkin lymphoma is that a lot of the older adults with Hodgkin lymphoma present with advanced stage disease at the time of diagnosis. They have a lot more comorbidities, and they have more aggressive disease at baseline. So we really need to figure out the best regimen for older adults, because oftentimes the regimens that are used in people who are in their 20s to 30s can be quite toxic. So as I mentioned, your oncologist may prescribe different regimens from what I'm listing here. And the purpose of these next sets of slides are to review the data from trials that are specifically in older adults. So the standard treatment that we use for Hodgkin lymphoma, as I mentioned, is often ABVD. It can be quite toxic. That B is bleomycin, and has an increased risk of lung toxicity, especially in older adults. So as people age, that risk increases. And this is really due to a difference in age, biology, and tolerability. So in the last decade, there have been a lot of studies that focus on how to tailor therapy. So first, the geriatric assessment has been used in many of these studies, and it helps people to determine whether someone is fit or unfit for treatment. And then if they're fit, then they'll go on for a very prolonged chemotherapy course, versus unfit, where they might get single agent chemotherapy or combination with immunotherapy. So I'll review each of these in detail. But before I go into the actual studies, I wanted to highlight some definitions that I'll be using. So overall response rate is the percentage of people who had at least some response to treatment. Partial response is defined as at least a 30% decrease in the size of whatever cancer lesion we're targeting. Complete response means that all the cancer disappeared. Overall survival is from the time of randomization on the clinical trial to the time of death from any cause. And progression-free survival is a time from randomization on the clinical trial until there was some objective tumor growth. So for fit patients with advanced Hodgkin lymphoma, there was a phase 2 study of sequential brentuximab vedotin and AVD. So in this study, the participants received 2 cycles of AVD, and the response rate to this was 82%. And actually, 36% of people had a complete response after those 2 cycles. So this was followed by 6 more cycles of AVD. So that's another chemotherapy regimen. And this had increased the overall response rate to 95% and a complete response to 90%. Then brentuximab vedotin was given for another 4 cycles. And overall, 95% of people had an overall response rate of, had some sort of response to treatment. And 93% of people had their cancer go away completely. Now, the main issue with this regimen is tolerability. It is a very long regimen. And what the researchers have found is that when people were considered unfit by that cumulative illness rating scale I showed you earlier, they had a harder time tolerating the therapy and completing the therapy, and they were more likely to have progression, meaning the cancer came back after treatment. Now, for people who are considered unfit, there was a clinical trial that resulted in 2 different publications where patients who were 60 and older had either single agent brentuximab vedotin or brentuximab vedotin combined with some other agent. And for people who received brentuximab alone, the overall response rate was 92%. So of those individuals, 73% had no evidence of cancer. And the amount of time until objective growth of that cancer or the progression-free survival was 10.5 months. Now, when you add dacarbazine to brentuximab vedotin, you get a similar overall response rate of 100% actually. So everyone responded. And then the complete response was a little less than single agent brentuximab vedotin, so 62%. However, you get a deeper response, a deeper remission. So it took 17.9 months for people to have any sort of objective growth of their cancer. And then the third arm had an even better response. It's brentuximab vedotin and bendamustine. But unfortunately, 65% of participants had some serious event, and there were 2 deaths. And so this arm was actually discontinued on the clinical trial. Another option, which I had highlighted in the initial slide, was brentuximab vedotin and nivolumab. So nivolumab is an immunotherapy agent that is used, and they studied it in first-line therapy for adults who are 60 and older, or people who are considered unsuitable for standard therapy because they had impairment of their heart, lung, or kidney function. Now, the median age was 71.5 years, with a range of 64 to 77 years. And of the 46 participants, only 2 were younger than 60. So they received 8 cycles of treatments, and 64% of people had some sort of response, with 52% of people responding completely. The main side effects were related to the brain and the spinal cord, or neurotoxicity, as well as numbness and tingling, or neuropathy. And then 1 person died from a cardiac arrest, which may or may not be related to the treatment itself. Now, shifting gears to a type of non-Hodgkin lymphoma, which is diffuse large B-cell lymphoma, the main regimen that's used is called R-CHOP, which I highlight here. And R-CHOP can be challenging for people because it can affect the heart function due to this doxorubicin. And it can cause bone marrow suppression, so people can have issues with making white blood cell counts. And so this study looked at decreasing some of those toxicities by reducing the doses of chemotherapy. So in this phase 2 study of adults 80 and older with diffuse large B-cell lymphoma, they gave reduced dose chemotherapy. So as you can see, I'll highlight here the dose reductions to 150 adults. And overall, 73% of people had some sort of response, with 62% of people having their lymphoma go away completely. And this effect lasted for a median time of 21 months. The caveat with this is that there were 12 deaths due to toxicities from the regimen, and about 40% had some severe neutropenia, meaning their white blood cell counts were so low, with 7% of them having to be hospitalized for fever. So this follow-up study was designed to help reduce some of those deaths and treatment-related side effects. And what they did was they replaced rituximab with ofatumumab, and they gave something called pre-phase treatment, meaning 1 week before therapy, they gave steroids and one of the chemotherapy drugs called vincristine, in addition to the chemo. Similar study design otherwise, with adults being 80 and older. And what they found was when they gave this treatment, there were no deaths due to treatment toxicities. The most common cause of death was lymphoma. And they were able to reduce the neutropenia, so the low white blood cell count problem, by 50%. So only 21% of people had this neutropenia. The same rate of people were still hospitalized, though, for, we call it febrile neutropenia, or fever in the setting of low white blood cell counts. So based on this data, I actually give steroids before a week before treatment for select patients.